please fill out the evaluation and the questionnaire, as it is part of us being able to get CME credit. Today we have Dr. Ronald Hamdi, who is a professor of internal medicine, holder of the Cecil Cox Quillen Chair of Excellence in Geriatric Medicine, and director of the Osteoporosis Center here at ETSU University. Dr. Hamdi did his postgraduate training at the University of London in England, and in 1977 was appointed senior lecturer and consultant there as well. In 1985, ETSU recruited him, and he's also served as the editor-in-chief of the Southern Medical Journal from 2000 to 2010. He's actively involved in research and practices here in Johnson City. He's published 4 books. His basic science research is on reducing the impact of cellular ischemia. His main clinical interests are metabolic bone diseases and dementia. And today he's going to be talking about aberrant behavior in dementia. Welcome.
Thank you very much. Thank you very much for the invitation. I'm very glad to be here. I'm very glad that so many of you have decided to come and spend the beginning of the weekend here with us. It's always refreshing to come back to psychiatry and see so many friends. Jim, it's great seeing you. John, great seeing you. Thank you for having me. Norman, good seeing you too. I'm always nervous whenever I have to talk in front of a group of psychiatrists because you guys know too much about me. So body language and expressions and whatever. Anyhow, I've been asked to talk about anything related to dementia. And I thought I'll talk to you about aberrant behavior in patients with dementia. I see this quite a lot. And a lot of what I have learned about aberrant behavior really is sitting down with patients and their relatives and go over some of the issues they're facing. So my objective this morning is hopefully to show you some of the mechanisms leading to aberrant behavior in patients with dementia, and what are the various strategies that can be used to avoid these catastrophic reactions, these aberrant behaviors from happening, and how to divert the energy of the patient towards a less destructive outcome. I don't have any disclosures to make. Usually, for the past few years now, most of my talks have been patient-centered. This talk this morning also is going to be patient-centered. But before I introduce you to some of my patients, I would like just to give you a brief overview of dementia. And as I said earlier, I feel a little bit nervous talking in front of so many experts. You see this every day. I only see it 2 or 3 times a week, but I've been doing it for a long time now. So, I first want to remind everybody here what is dementia. It is an acquired decline, and the word acquired is very important to differentiate it from other types of cognitive dysfunction, and it is associated with impaired judgment. We've got many different types of dementia. Most of them we can differentiate clinically, but it's very important to differentiate them because the implications are quite different. The first type everybody is very familiar with, Alzheimer's disease. I won't go into details with any of them, but it's important to remember that with Alzheimer's disease, we've got the 4 A's. It's not just the memory that is impaired. Memory for recent events is quite impaired, but that's not the only one. The patient also has difficulties naming objects, has difficulty recognizing things, and we will see in a few minutes how important agnosia is, and also the patient develops apraxia. She's unable to carry out voluntary activities even though there is no localized muscle weakness. And you will see how especially the agnosia as well as the anomia and amnesia can lead to some aberrant behaviors. The next common type of dementia is Lewy body dementia, and we've got to bear this in mind because it is apparently the second commonest type of dementia here in the US. And the hallmark is not so much impaired memory as much as it is hallucinations. And these patients have very vivid hallucinations. They're not usually threatening hallucinations. The patient imagines that there is somebody talking to him or to her, so they are formed hallucinations. Sometimes the patient can have a conversation with these people, and then often the patient would realize, oh, yeah, that's just hallucinations, at least in the early stages. Another important thing to remember about Lewy body dementia is that they have a lot of fluctuations. And the fluctuations are not only as far as cognitive skills, but also as far as degree of consciousness. So they could be somnolent and sleepy for 1 minute, and the next minute they're fully alert, and 2 minutes later, again, they're quite somnolent. And it is these fluctuations in the level of consciousness as well as cognitive dysfunction that is very concerning. And a lot of relatives think that these patients are putting an act on, that these patients are having them on, that they're not really somnolent, they're not truly impaired cognitively, because 2 minutes later they're quite all right. And it's something that we need to ensure the relatives are really fully aware of it. Lewy body dementia, also one of the hallmarks, is rapid eye movement behavioral disorders. Most of us, when we dream, when we have nightmares, we're totally paralyzed. Our eyelids may move, they do move. Not the eyelids, our eyeballs move quite a bit. That's a period of rapid eye movement. But otherwise, we are paralyzed. Patients with Lewy body dementia are not paralyzed, and therefore they may enact their dreams, and the patient may hit, may kick whoever is in bed with him. They also have extrapyramidal signs, which is a useful sign to pick up in a patient with dementia. I'll talk more about this in a minute. But if the extrapyramidal signs and the dementia both occur within 1 year of each other, diagnosis is likely to be Lewy body dementia. If it's more than 1 year, it's probably the Parkinson's dementia. Mustn't forget about multi-infarct dementia. It's still quite prevalent, especially in patients whose atherosclerosis is not well controlled. They may have diabetes, they may have hypertension, they may have hypercholesterolemia that is not controlled. Usually there is a source of embolization. Often you can see thrombi there. Most of these patients have neurological deficits, and also they have a stepwise deterioration. Frontotemporal dementia, we also see it, and the hallmark is not only disinhibition and antisocial behavior, but also anomia, where they have difficulties naming objects. Unfortunately, we've got increasing, and we've got a world expert, our chairman here, with HIV dementia. Prevalence is increasing, and we need to be aware of it in certain populations. Hydrocephalus, I don't think most of us here will see it very frequently. I've seen it only a handful of times. The typical presentation is muscle rigidity interfering with the gait, leading to ataxia and urinary incontinence. The three of them, the dementia, incontinence, and ataxia, occurring within a very short time span. It's important to pick it up, because if you do in time, a neurosurgeon can be very helpful. Parkinson's disease, most of the patients with Parkinson's are cognitively intact. Some of them develop dementia, and the 1 year rule, which is often applied, is that if the patient has the signs of Parkinson's and develops dementia within 1 year, Iatrogenic dementia is another thing that I'm sure all of you are very much aware, but it's so easy not to pay attention to it, not to pick it up. And with iatrogenic dementia, I also include alcoholism, alcohol abuse. I've practiced geriatric medicine in 3 continents. I've visited many, many places, and everywhere I've been, if there is an older person who wants to have an alcoholic drinks without the caregivers noticing it, that person will be able to get it. They're always able to, and we need to bear this in mind. Also, don't forget that alcohol interferes with other medications the patient may be getting and increasing their sensitivity to various psychotropic medication. So iatrogenic dementia, we need to look out for it. I've also included this, and I know I'm addressing a group of psychiatrists, but I really want to mention it because many patients with depression present with impaired mental functions, and it's very easy to put the label of dementia on a patient who essentially is depressed. And this is very unfortunate because, as we all know, the treatment of dementia is really quite good, quite successful, and now you guys have so many things to offer the patient that it would be a shame to miss it. Rare types of dementia, we see them. We still see B12 deficiency, especially in patients who have undergone bariatric surgery. Jakob Creutzfeldt is gaining popularity again, and various other prion-induced dementia. So this is just a very broad bird's eye view of the various types of dementia. I think it is very important to try and identify the type of dementia because, as you can see, they're quite different, and the problem a patient with Alzheimer's disease has may not be such a big problem in a patient with multi-infarct dementia. Again, a problem in a patient who has frontotemporal dementia is going to be different from that with Alzheimer's. So it behooves us to try and make a clinical diagnosis of the type of dementia, and that dementia in itself is not a diagnosis. Dementia, I say, is the same as headache. To go and say, I've got a headache, doesn't really mean much. You need to find out what is the cause of the headache. And the same thing with dementia. And I hope by now you are convinced that senile dementia is not an entity. We should not use the word senile dementia. It really is meaningless. If anything, I think it's derogatory to the patient to tell him you've got senile dementia, or to tell the relatives that your loved one has senile dementia. Clinically, the features are so different that we should be able to. And it's important not only for making the diagnosis, but to be able to tell the relatives what sort of problems to anticipate with their patient, because the problems are quite different. So what I would like to do now is to just highlight some of the features that lead to aberrant behavior. We have the impaired short-term memory and short attention span, and these are seen mostly in patients with Alzheimer's disease. And both of these enable the patient to cope with multiple stimuli. And it's as if the patient is frozen. The patient has choices or is offered choices and cannot make up his mind what to do. You often see this very frequently if the patient goes to a restaurant. I'm talking about early stages, very early stages, and he looks at the menu and cannot decide what to get, and is getting more and more frustrated. And you have the waiter who keeps on hovering around, and whoever is sitting at the table with the patient is getting impatient. Please make up your mind. What do you want? And the patient just cannot make up her mind because she's got an impaired short-term memory, because she's got a short attention span. By the time she reaches the 4th or 5th item on the menu, she can't cope, let alone the menu where they have 5, 6 pages of various items. The patient also has apraxia and agnosia, and these two, we'll see in a minute, do interfere with the daily activities. In addition, patients with Alzheimer's disease often have paranoid delusions. Above all this, there is impaired judgment, which has involved every cognitive function. So the impaired short-term memory, as well as a short attention span, leads often to repetitive questionings. And repetitive questioning is one of the things that most caregivers cannot tolerate easily. They find it more and more difficult to cope with the patient asking all the time the same question over and over and over. The relatives answer the question. 20 seconds later, the same question is asked. And I'll show you one typical example in a few minutes. The short attention span, the inability to cope with stimuli, as well as the agnosia, the three of them work together to make it very difficult for the patient to make choices. And I'll show you another case in a few minutes. Agnosia is something that we often overlook. The patient doesn't recognize things. And it's easy to say the patient sees a pen or a pencil and thinks a pen or a pencil is a spoon and would eat her soup with it. Much more important is the patient who does not recognize that the food she's about to eat has gotten rotten. Because when we see food, we can tell whether it is good, whether it is fresh, whether it is edible. A patient with Alzheimer's who doesn't recognize that the food has gone bad may actually eat it and have food poisoning. The patient may not recognize that it is cold outside and may go out for a walk not appropriately dressed. The patient may not realize that, oh, the red light is, I need to stop. The patient may not realize that the space she's trying to park the car in is too small. Physically, there is no way she can get the car there. And most of these fender-bender accidents are because of agnosia. The patient is unable to take in various stimuli, integrate them, come up with an answer as any normal person would do. And this is because agnosia. And it's important, I think, to tell the relatives this very early on. This is a problem that will arise later on, because let's face it, unless Dr. Norman Moore comes up with a very good medication, we still haven't got any medication that is going to change the progress of the disease, at least for the next few years. Correct, Norman? Okay. So at least for the next few years, this is going to be a major issue. So it behooves us to let the relatives know what is ahead of them. And I'll show you cases. Again, it's because of the agnosia that the patient often gets lost, cannot take in the various reference points and say, oh yeah, I'm here, and I want to go there, therefore I need to follow this path. The agnosia interferes with the activities of daily living, and because of agnosia, the patient may make bad decisions, and this is often exacerbated by the patient having paranoid delusions, and these two together would lead the patient making bad decisions. I'll show you an example in a few minutes. Apraxia also eventually would lead to interference with the daily activities, simple things like getting dressed and undressed. The patient may not be able to do it, or shaving. The patient may not be able to do it. So this is my brief overview. What I would like to do now, if it's okay with you, is to share with you real cases that I have come across over the past few weeks, months, and some of them more than a year ago. So Martha is 70 years old. She's been diagnosed with probable Alzheimer's disease, stage 1, about 2 years ago. And you notice I use the word probable because, let's face it, clinically we cannot make a firm diagnosis. To make a firm diagnosis, we need imaging. We also need a microscopic examination. So she's got probable Alzheimer's disease, stage 1, diagnosed 2 years ago. Her husband died a year ago. She now lives with her daughter, Doris, who has a 4-year-old daughter herself. And Doris is not married. I want you to visualize the scene. It is Sunday morning. Martha, who's not too bad at all, prepared breakfast. It was a very good breakfast, beautiful weather outside, and it's one of these days where harmony really exists between everyone in this household. Martha, her daughter Doris, and her granddaughter. They just had breakfast. And Doris thinks it would be a good idea to go to church. So she tells her mother, it's 9 o'clock, we need to leave in half an hour to go to church. I want you to go upstairs to your room, pick up a dress, and get dressed. Martha agrees. She goes to her room. 5 minutes later, Doris is a bit concerned that her mother may not be able to get dressed or whatever. So she shouts at her, "Mother, are you ready? 5 minutes gone. We've got another 25 minutes to go." Doesn't hear anything. 25 minutes later, it's almost time to go. Over the past 20 minutes, every 5 minutes, Doris called her mother. And now there are only 5 minutes left before it's time to go to church. Doris walks into Martha's room. She finds Martha, her mother, sitting on the bed, crying with clothes all over the place. She's furious. She's very unhappy. They start an argument. The argument escalates. It gets very personal. Her mother tells her, "If your dad was alive, he wouldn't have allowed this." Doris says, "Dad was a saint. I don't know how he coped with you. There is no way anybody can cope with you. I cannot cope with you. I've got my own daughter. I've got you to take care of. You're not helping me at all." And the last insult is Martha turning around and saying, "Who are you to talk to me? You can't even keep a man. You're an unmarried daughter. Shame on you." Catastrophic reaction. The question is, could it have been avoided? So let's go back and try and see where are the turning points that could have changed the ultimate outcome. The first one is when Doris tells her mother, "Mother, it's 9, we need to leave in half an hour. I want you to go to your room. I want you to pick up a dress. I want you to get dressed. I want you to come with us to church." Telling patients with Alzheimer's disease is a red flag. Don't forget, many of them have paranoid tendencies. Many of them think that everybody is having a go at them. They are the victims. They feel that they are the victims, and everybody is abusing them. And this is a red flag. So rather than Doris telling her mother, "Mother, I want you to go to your room. I want you to pick up a dress. I want you to get dressed. I want you to join us and come to church," what Doris should have done is, "Mother, what do you think? It's 9 o'clock. We've got time. How about going to church today? Do you think it's a good idea?" And chances are very high that Martha would have said, "I'm not so sure. I think I'm going to stay." Because again, patients with Alzheimer's disease, because of their agnosia, because of their anomia, they're unable to recognize the people. So every time they go to church, for instance, they're faced with a multitude of people who they don't know at all, and yet most of these people know them. And this is very, very unnerving. And this is one of the reasons why patients with Alzheimer's disease prefer to avoid social gatherings, because they hardly know anybody. And can you imagine what it is every single day going to a place and you haven't got a clue who these people are? And the unnerving thing is that they know you, but you don't know them. So the whole situation could have been avoided if Doris had asked her mother, "Do you want to come to church or no?" And if Martha said, "No, I don't want to," that's it, end of the story. And the whole situation would have been avoided. Because once things like this happen, where Martha tells her daughter, "Shame on you, you're an unmarried daughter," it's a wound that has been inflicted. And even if it heals, it's there. It's been done. It's been said. The other turning point is when Martha has to make a choice. And I want you to visualize this. Martha going to her room, opening the cupboard to decide which dress she's going to put on. And let's say she's got 5, 6 dresses there. Picks up the first dress. "Oh, gee, that's nice, yeah. Should I wear it? I'm not so sure. Let's see what the other one is like." Puts it back, pulls the other one. That's not too bad at all either. Let's see what the next one is. Puts it back, pulls the third one. Now she's already forgotten what the first one is like. And it keeps on going on, and she gets herself into a vicious cycle where the more she looks at various options, the more confused she becomes, the less able she is to make a decision. Patients with Alzheimer's, even early on, once they're unable to make up their mind, it's best not to ask them to make decisions. What Doris should have said is, "Mother, you agreed to come to church. I put a dress on the bed. I would like you to go and put the dress that I have left on the bed. Put it on. No choice at all, just one dress. Put it on. And Martha would have been able to cope with this much, much easier than having to make her choices. Because of the impaired memory, because of the short attention span, and also because of the easy distractibility, these patients are finding it very, very difficult to make choices. Whether it is a menu, whether it is a dress to put on, whether it is to turn left or to turn right at the crossroads. To compound this, they become frustrated. And the more frustrated they become, the more difficult it is for them to make decisions. And that vicious cycle keeps on going on and on and on. And the patient is just unable, gives up, and as Martha did, sits on the bed and cries. Too many choices confuse patients with Alzheimer's disease, and they should be avoided. I usually tell the caregivers, as much as possible, do not offer choices. If you find that the patient has difficulties making choices, if the patient can cope with it, that's fine. But as soon as you find the patient is unable to make choices, avoid them. Calling at 5 minutes interval. It's sometimes very important because patients with Alzheimer's have a short attention span, they're easily distractible. So they need reminders. But the reminder shouldn't be a jolt. It should be a gentle reminder. Doris should have gone to Martha's room and say, how are you getting on? And she would have found early on that Martha cannot make up her mind. She gets past the third dress, she cannot make up her mind anymore. So the daughter should have helped her. Here, mother, I think this dress is very good. Now I've got to run back and take care of my own daughter. But here, this is the best one for you. Don't you think so? Or do you remember that dress you wore it at these occasions? Of course, she doesn't remember, but doesn't make any difference. The patient is involved in the decision-making process, and she doesn't have choices to make. She puts on the dress that is in front of her. And this is what's been happening with these. Every reminder, every time the daughter called her mother to say, 5 minutes gone, it's time to go, it increases the level of frustration, makes the decision-making process even worse. So reminders, although necessary, they can often increase anxiety and further impair cognition, and all this ends up in a catastrophic reaction, and argument develops. As much as possible, avoid arguments with patients who have dementia, especially Alzheimer's type. There is no way you can win. And it's important for the caregivers to realize this. Do not argue with the patient. I'll show you a couple of examples in a minute. Because the patient most of the time doesn't listen, or he may just pick up the last thing you said and take you in a completely different direction. So as much as possible, arguments should be avoided, and especially escalations, because once an argument starts, it will gradually escalate. The best thing to do is to withdraw. Go and have a drink of water or a vodka or gin or whatever it is. Do something, but do not escalate the argument. So we need to avoid arguments. We also need to reassure the patient and show love and affection to the patient. Patient with dementia, especially Alzheimer's disease, they need reassurance. The patient themselves, I'll talk more about that in a minute, are very much afraid. They do not understand what is going on. They know that there is something wrong. They can't put their finger on it. They're very concerned. They're afraid. They need reassurance. They need to show, they need the caregivers to show them love and affection. So, what I've been trying to tell you is that that catastrophic reaction could have been avoided. There are 6 turning points that could have been avoided. From the first one, don't tell the patient, ask her, what do you think? Shall we go to church today? Do you want to come or not? I left you one dress, please go and put it on. 10 minutes later, mother, are you okay? No, I can't decide which one of these dresses. Here, take this one. No choices. The argument develops. Stop it. Go away and come back later, and we can discuss the issue. Are we all right? My next patient is a man. He's 70 years old. He's got stage 1 Alzheimer's disease, diagnosed a year ago. He lives with his son Paul and his grandson Peter, and they're watching a football game. Lewy, who's got Alzheimer's disease, is nodding off. The game is boring, is very predictable. Peter is getting edgy. He wants to go for a drive. So he tells his dad, I'm going to go for a drive. His dad is a little bit concerned, so he talks about Peter being cautious driving. In the process, Lewy wakes up. He hears driving. He hears, I want to take the car. He hears the dad saying, be careful in the traffic. And Lewy decides, I want to go on a ride. Where are the car keys? Give me the car keys. I want to go. Both Peter and his dad say, oh, you can't drive. Why can't I drive? Don't you remember doctor's orders? You saw the doctor 2 days ago, and he said you cannot drive. I don't remember seeing any doctor. Who's that doctor anyhow? Don't you remember Dr. Moore? You saw him in the office, and he said that you shouldn't be driving. I don't remember any Dr. Moore. Who's Dr. Moore anyhow? He's a psychiatrist. Psychiatrist? I'm not going to see any shrinks anymore. No, I don't know. What does he know anyhow? He's a psychiatrist. Let him take care of patients. Let him mind the patient's mind. I'm going to drive. Nothing to do with that doctor. Where are the car keys? And the argument gradually evolves. It develops, it escalates, and it ends up with a physical confrontation where the patient is trying to grab the keys from his grandson. His father interferes. They try to separate, but it's too late. Physical confrontation has developed. Very easy to happen. So, could it have been avoided? Of course it could have been avoided. And the number one is avoid triggers. There was no reason at all to have this argument while Lewy was sleeping, especially about something that the MD told the patient he couldn't drive 2 or 3 days ago. What should have happened is Peter should have told his dad, I'm going to go for a drive, is that okay? And Lewy probably would have continued to sleep and not noticed. The other thing is the keys. Why were the keys left fully exposed? The keys would remind the patient of driving. And the car was left outside in the drive. So there were many triggers there for the patient wanting to go and drive. And the best thing, if the patient is not allowed to drive, is eliminate all these triggers. Don't talk about driving in front of the patient. Don't leave the car keys in a visible position. Don't leave the car there. Or disable the car. So the first thing would be to avoid the triggers. Second thing is avoid confrontations. Again, we said earlier, do not tell the patient, do not order the patient around, and again, do not confront the patient. If the patient says, I want to drive, to tell the patient, no, you cannot drive, Dr. So-and-so told you you cannot drive, you're confronting the patient, you're inviting an argument. Why can't I drive? Who said I can't drive? This is my car. I paid for it. The argument should be avoided, escalation should be avoided, and what can be done is divert the patient's attention. So when the patient says, I want the car keys, I want to go for a drive, one thing that could have happened is his son say, oh, Dad, sorry, I should have told you. We've been having problems with the car, we called the mechanic, and he's going to have a look at it tomorrow. You can't drive today because the car isn't working. But come, I want to show you something. I've been having problems fixing this tap or the faucet or whatever it is. So not only do you avoid the confrontation, but you divert the patient's attention. And if you can do this in a way where the patient feels needed, Dad, I meant to ask you, I've been having problems fixing that drawer. Do you think you could come and help me out? You are making the patient feel important. You are making the patient feel needed. You are diverting his attention. And now instead of his goal being to drive the car, his goal is, I'm going to help my son and my grandson fix the cupboard or the drawer or whatever it is. In this way, you appeal to the need of the patient being needed. All of us have a very, very deep need. And I hate to say this to psychiatrists, but you know very well, the need to feel needed is very deep-rooted. All of us like to feel needed in one way or another. And patients who have dementia have this same need. and it's sometimes difficult to satisfy. If the patient cannot drive, hide the car, get rid of it, sell it, disable it, don't leave it there in full sight. So, my thesis is that that catastrophic ending also could have been avoided. Let's move on to our third patient. This is Marjorie. She's 74 years old, Alzheimer's disease stage 2, diagnosed a year ago. She lives with her daughter, with her son-in-law, and granddaughter since her husband died because she could not cope on her own anymore and could not afford to go into an institution. I want you to picture this. They're all sitting down. It's evening. They had their dinner. It was quite a good dinner. They're in the sitting room. The TV is switched on, and each one is occupied doing something while the TV is still going on. So hardly anybody is watching TV, but it's there. There is a program about violence. And Marjorie, who's the patient, asks repeatedly, are the doors locked? And she gets the same answer, yes, mother, the doors are locked. The program is now over. They try to have a conversation, but every few minutes, Marjorie is very concerned. Are the doors locked? Yes, mother, the doors are locked. Oh, thank you. I just want to make sure. They talk for a few minutes. Are the doors locked? Yes, mother, we told you, the doors are locked. They talk for a few more minutes. Are the doors locked? Yes, mother, we told you they're locked. And eventually, they become more and more irritable, and now instead of politely saying, yes, mother, the doors are locked, it starts to become inflammatory. The son-in-law and the granddaughter both leave. The granddaughter has homework to do, and the son-in-law is preparing grand rounds for psychiatry. And he says, I've got to go and get my slides ready. Marjorie is knitting. Her daughter is reading a book. Repeatedly, mother asks, are the doors locked? Her daughter gets very upset, can't take it anymore. She goes, literally grabs Martha and says, come, I'll show you. And she pulls her. There's the door. Is it locked? And there's another door. Is it locked? And there's a window here. Is it locked? So now please go and sit there and let me finish my book. Martha said, I'm sorry, I didn't really mean to upset you. I was just concerned. Daughter goes back to her chair, sits down, hasn't read half a page. Are the doors locked? It ended badly because she physically injured her mother. Could it have been avoided? Very, very, very common situation. Same question asked over and over and over is testing the caregiver's patience, testing their resolve, and sooner or later they lose their temper. So, the first thing, avoid triggers. Why watch a program on violence just before going to bed? Especially if the violence is in the neighborhood. Nobody was watching anyhow. Everybody was doing something else, but in the background was that program about violence. Do we really need that program? That's a trigger that could have been avoided. The other thing that caregivers often overlook is that they keep giving the same answer. But just think about it. I ask a question, I'm given the answer, yes, the doors are locked. My way of understanding the response is just auditory. I hear something, and that something is, yes, the doors are locked. But it's just one sense. We have 5 senses, and of these 4 can be used. So not only do we need to say, yes, mother, the doors are locked, it's here, let me show you. Take the patient, and now we have auditory and we have visual. Can also have tactile. Here, mother, check, the bolt is locked. And now you're exponentially increasing the stimulation. Not only is it auditory, it's visual, it is tactile. You can also reinforce it. and have a small notice board, doors locked. And you reinforce the message to the patient and in a way try to avoid the repetitive questioning. And when the patient asks, are the doors locked? Everybody points to the board. And mother sees, oh yeah, that's fine. And the whole thing becomes lighthearted and not as taxing as the same question, same answer giving over and over and over again because it doesn't lead anywhere. So to more than one sensory modality would help the patient appreciate more that the doors are locked because we're using more than one pathway in the brain. The other thing that is very useful is to divert the patient's attention. Get the patient to do something. Oh, mother, you know, I've got a pile of linen. Would you come and help me fold them and put them in the drawer? You know, Peter was visiting the other day. His room is in a mess. Would you come and help me sort that room out? We need to fix lunch for tomorrow. I'm going to be late. Why don't you come with me to the kitchen and we'll fix lunch for tomorrow? Or I don't know about you, I'm a bit peckish. Anybody else peckish here? Let's go and prepare something in the food, in the kitchen. So this way you divert the patient's attention. And again, the other thing that I've become very much aware is that need of being needed. You give the patient something, the patient feels useful, the patient feels she is contributing to something. Above all, reassure the patient and show her love and affection. And my contention is here too, that catastrophic reaction could have been avoided. Let's move on. Bill is 71 years old. He's got Alzheimer's stage 2 that has been diagnosed a year ago. He's sitting on the front porch. His wife is preparing lunch. It's a beautiful day outside. A truck pulls up. A polite, well-dressed gentleman approaches Bill. And he says that he and his men are working on a house down the road. He compliments Bill on how well the house is kept and really flatters Bill and butters him up, and Bill falls for it and he feels happy, he's flattered. The man points out to Bill that unfortunately the drive needs to be resurfaced and it's really not doing justice to the house. You've got such a beautiful house and the drive is not really all that pretty to look at. It really also diminishes the value of your house. And Bill looks around and, yeah, it makes sense. Yeah, the drive needs work. So the man tells him the usual cost is $1,200, but he could do it for just $495 because his men are down the road and they've got all their equipment. And they could resurface the drive the following day. And instead of paying $1,200, Bill has only to pay $495. Bill is happy and says, yeah, that sounds reasonable. $1,200, $495. And you can start tomorrow? Yes, sir, tomorrow. And you can finish it in one day? Absolutely. All be done by tomorrow evening. Tomorrow, like now, you'll be enjoying a brand new drive. So Bill is happy. And the man says there's only one problem. It's getting late in the day. The banks are going to close. So either give me cash or give me a check made for cash. I'll go and check it, cash it, and then I'll go and buy the goods and we'll start working tomorrow. Bill says, yeah, okay, that's fine. So he goes in the house and starts to write the check. His wife notices something and she says, what are you doing? And Bill initially is coy, but then says, I'm going to resurface the driveway. She is upset. She doesn't want it to be done. She says, well, who's doing it? Where do you know this man from? Have you seen his work? And Bill, of course, doesn't know anything at all about the man. So she says, well, you can't do it. And they start arguing. Well, what do you know about surfacing the driveway? What do you know about hiring people to do the work? And the argument develops and escalates. Bill ends up hitting his wife. She falls and fractures her hip. Question, could that catastrophic ending have been avoided? And here too my contention is absolutely. It could have been avoided if Bill's wife knew how to handle him. So, avoid confrontations. Bill is writing the check. You either tell Bill, oh, you can't write the check. No, Bill, you can't do this. I don't want you to do it. and then confrontation develops. Another way of doing it, oh gee, Bill, I'm sorry, I should have told you this. I needed some money. I drew it from our current account. There isn't enough money there. It would be so embarrassing if this man went for the check and the check were not cashed. Please forgive me, I should have told you this ages ago. But let's leave it a couple of days. We'll pull money from our savings account, we'll replenish the account, and everything is going to be fine. Attention diverted. Another ploy, oh, I meant to tell you this. I spoke with the neighbors and their son who's going to college in a few weeks' time. He's got the other people that are working with him, and they offered to resurface our driveway as well as the neighbors. I've already promised them. I'm sorry, I should have told you. I didn't, but please forgive me. But I'm sure they're going to do a good job. Another ploy, oh, that's a brilliant idea. Take me, introduce me to the man. And then when you see the man is, where are you working? Where is your office? Who are you working with? Show me your credentials. But don't confront the patient. Confrontation, patient with dementia, doesn't work. This is how arguments develop, and then very easily they escalate. So avoiding confrontation, diverting the patient's attention is a very useful ploy. Make excuses. I'm sorry I used the money, we had to spend it on whatever. It's going to be replenished. Offer alternatives. The neighbor's son is going to resurface it. Distract the patient. As soon as you tell the patient, I'm sorry I pulled the money out because we needed the cash to buy or to do whatever, but here I prepared lunch, why don't you come and have lunch? I've got your favorite lunch on in the stove. Come and let's have lunch. And you divert the patient's attention, you distract him from the main thing. Ask the handyman for credentials and references. And the other thing is to ensure that appropriate legal steps are taken to ensure that the family's assets are kept. So for instance, one thing that could have been done is that a check that is signed only by the patient is not valid. You need 2 signatures, or limit the amount on the checks that can be thrown. And there are quite a lot of legal steps that can be taken to ensure that the assets are not wasted. This is a sad story, but it's true. David is 68 years old. He's got Lewy body dementia. It was diagnosed a year ago. He's a retired Marine. He's got Lewy body dementia, also has PTSD. It's about 3 o'clock in the morning. His wife is asleep in her room, in their room. David is very anxious, apprehensive, restless, and agitated. He hides behind the couch, peeps above it, listens for noises, crawls to the window, raises himself sufficiently to take a quick furtive look, pulls out a handgun from the drawer, gets some ammunition, loads the gun, picks some extra ammunition, puts it in his pocket, crouches on the floor behind the couch, peeps through the window, lifts up a pair of binoculars to his eyes, looks out of the window, puts it down again. The man is very agitated, slowly gets up from his hiding spot, throws his gun, walks towards the bedroom where his wife is sleeping. He looks around quickly, slowly opens the bedroom door and surveys the room. Mary is sound asleep. Very slowly, he gets close to her and whispers in her ear, "Don't worry, I've got everything covered. They will not capture us alive." She wakes up, doesn't know what the heck is going on. She wants to sleep. David is agitated and very worried. He tells her, "We've got people outside. They're going to come." She tries to reassure him, but she cannot. He says, "I've seen them. Here, my night goggles." And she looks at them and says, "You stupid so-and-so. These are binoculars. They're not night goggles." She ridicules him. He shows her the loaded gun. She shrieks, jumps out of bed, runs away. He shoots her and then shoots himself. Could it have been avoided? My contention is yes, it could have been avoided too. But again, hindsight is 20/20. But the usefulness of these is to sit down with the caretakers, with the caregivers, and go over the various possibilities. So the first thing is not to disagree with the patient. This may raise some ethical issues. A patient who's hallucinating, do you try to talk the patient out of these hallucinations? Do you try to tell the patient, no, you're just imagining things, these are hallucinations? Or do you agree with the patient? And we can debate for hours this issue ethically. Do you encourage the patient with? The point I'm trying to make is, regardless of your ethics background, whether you want to tell the patient it's not true or whether you agree with the patient, my contention is don't disagree with the patient. Don't say the hallucinations are true if you feel are not true if you feel uncomfortable. And don't condone them if you feel uncomfortable. But the point is, try not to disagree with the patient. Very important to reassure the patient. The patient is scared. The patient needs reassurance. He also got a loaded gun. Exploit the patient's need to feel needed. Oh, gee, Dave, I'm so happy you're here. I'm so relieved. You're going to take care of me. You're going to protect me. Offer an alternative. I'm so happy you did this. You look very tired. Why don't you rest? Let me take the first watch here. Give me the gun. I'll take care of the people who are outside. And if they come near, I'll wake you up. But I really want you to rest so that tomorrow we can face that situation. Again, you're exploiting the need to feel needed. Distract the patient. And the distraction has to be done immediately. When you unsettle the patient, you're trying to focus him on something else. You've got to offer an alternative. I need your help to do this. Come and have a look at this. I meant to show it to you. And the other thing is, if the man has a gun, please don't run away from the situation. It's a very good target. Ideally, the situation could have been avoided altogether, and I'm apprehensive of mentioning this, but maybe guns, we should revisit the issue, at least if there is a patient with dementia who lives at the home. At least in these situations, guns should not be readily available. If the caregiver needs absolutely a gun, it should be kept under locked key, not easily accessible. The ammunition should not be next to the gun. But again, we can debate this for ages. Okay, so let's try and wrap up so we can have a few minutes for discussion. These are some of the underlying mechanisms that may lead to aberrant behavior. And what I've tried to show you is that most of the time, these are not really aberrant behavior. These are behavior that have been set in the way the stories have developed. All these stories are true. All these stories ended up with an aberrant behavior. But is it really an aberrant behavior? Or is it a behavior that is due to the underlying pathological process? And my hypothesis is that most of these behaviors, which we call aberrant, are not really aberrant. They're a result of the patient's underlying pathology. And we need to understand this. We need to make the caregivers understand it. So what are the main ones? Well, we've got the short attention span, very high on the list. Impaired memory for recent events, inability to cope with multiple stimuli, agnosia, paranoid delusions. We haven't had time to talk about altered circadian rhythm, but we did talk about hallucinations, and we didn't talk about this inhibition. So there is a rationale for these behaviors. And once you can rationalize them, they don't become aberrant and they don't become abnormal. It's a normal reaction of the patient given these circumstances. And it behooves us to tell the caregivers to be aware of these situations. They may arise any time. Should they arise, this is what we suggest. If your patient has a gun and tells you he's going to protect you, don't ridicule him. He's got a loaded gun. Find a way of taking the gun without wrestling him. So you tell him, I'm going to take the first night watch, you take the second, you go rest. Tell him, let's go together and check all the doors. Here, give me the gun. I'll carry the gun, you check the door. And finally, what are some of the strategies? We need to avoid triggers. If the patient cannot drive, don't leave the car just outside in full view. Avoid confrontations. Don't tell no to the patient. Avoid arguments, and as soon as they escalate, just withdraw. If Lewy says, I want to drive, this is my car, I paid for it, the MD so doesn't know what he's talking about. Don't argue, it's pointless. Try to distract the patient. Above all, we need to reassure the patients. We need to appeal to their need of feeling needed, of being needed, and we should show love and affection. Above all, we've got to remember that the patients do not understand what is happening. They are afraid, and we've got to reassure them. And this is terribly important, to show the patients that they're loved, there is a lot of affection going on. We try to understand, but the patients themselves don't understand, and we've got to reassure them because they are scared. And the caregiver, as much as possible, should realize what is going on and how to avert these. And this is where I'm going back to my starting point with the support groups. I found them extremely useful, and the people who came to these support groups found it extremely useful, because now they better understand what is going on, they can predict it, and they can take some action to avoid these catastrophic reactions from occurring. When everybody is scared, everybody is afraid, the outcome is not likely to be good. And this is where the caregiver really needs to keep her cool, her calm, know how to handle the situation, and will have better results that way. You've been very patient. I don't think I lost many of you. Thank you very much. I'll be happy to take any questions. Thank you.
When you're interviewing relatives, initially, they're always looking for a quick fix. And obviously, the quick fix they're used to is medication.
Right.
Are any of the drugs currently available, like Aberrant and actually useful in helping people?
There are some medications that we use as much as possible. You know me, we've been working together for a long time. I don't like to use the medication unless absolutely